but does it do what it says on the tin? What I hope to convince you of in the next 20 minutes isn't that AI technology providers and purchasers in healthcare are rarely able to answer that question, it's that the question is rarely asked. If it was, and if AI tech developers expended more R&D dollars and healthcare systems expended more healthcare dollars trying to answer the question, then I genuinely believe that paradoxically we would see a far more rapid adoption of AI technology in healthcare to the benefit of all. I'm not alone in this belief. To quote Eric Topol, if you really believe in your algorithm, then you will want to do a prospective validation trial and provide proof for the medical community, because otherwise this is not going to get legs. Before I focus on evaluating AI health tech, I want to briefly talk about evidence-based medicine generally and medical device validation in particular. Many people outside medicine are quite surprised to hear that the practice of medicine that is based on scientific, experimental evidence of whether a treatment actually works or not is relatively new. The use of empirical experiments to prove that treatments work is actually very old. It just took a very long time for medical practice to become truly evidence-based. It took almost 200 years, in fact. The first experimental study of a medical intervention was published in 1753 by the Scottish naval surgeon James Lind. The major cause of mortality and morbidity amongst 18th century sailors wasn't cannonballs but scurvy, caused by vitamin C deficiency. Lind divided a group of sailors suffering from scurvy into 6 subgroups and gave each subgroup one of 5 different popular treatments of the time, plus his own proposed treatment of lemons and oranges. Citrus fruits proved to be extremely clinically effective, but in a pattern that was to be repeated right up to the present day, it took decades for the treatment to become widely adopted by sailors. You have to fast forward almost 200 years to 1948 to find the first example of a true randomised controlled trial for the treatment of tuberculosis. Yet, even though RCTs, as they became known, became the internationally accepted standard by the 1960s for studies testing the effectiveness and safety of drugs and other treatments, it still took and often still takes decades before the accumulated evidence from those studies changes routine clinical practice. As Dr. Abraham Verghese from the Department of Medicine at Stanford wrote earlier this year, medicine itself is at a moment of crisis. As a profession, for all the extraordinary advances in the art and science of medicine in the last 4 decades, we have too often failed our patients. We fail to follow proven guidelines, and we fail in the art by not seeing the unique person in front of us. Despite all the efforts of clinical researchers and organisations that produce scientifically valid clinical guidelines, too many medical treatments don't do what they say on the tin for too many patients. A study published in Nature in 2015 looked at the number of people who actually had a beneficial clinical response to the top 10 most prescribed drugs based on gross sales. For the number 1 top-selling drug, aripiprazole for schizophrenia, in only 1 in every 5 patients did the drug actually work. For the number 2 drug, esomeprazole for heartburn, the success rate is woeful. The drug was effective in only 1 in every 25 patients. For the number 3 drug, adalimumab for arthritis, 1 in 4 patients respond. And for the number 4 drug, rosuvastatin for high cholesterol, the drug works for 1 in 20 patients. All those patients taking those tablets religiously, day after day, continue to take these drugs whether they work or not. If our most commonly prescribed drugs don't do what they say on the tin most of the time, do medical devices fare any better? I'm afraid the answer is we have no idea, because the evidence base for medical devices is very poor compared to drug treatments. When a new medical device gets a European CE mark, that doesn't mean that it's been convincingly shown to be clinically effective or even clinically safe. It just means that the device complies with some pretty basic essential requirements. The US regulators at the FDA tend to demand a bit more evidence than EU regulators, but not much more. So, for example, Medtronic developed a device called guard wire, which sucks out clots from coronary arteries during angioplasty and stenting procedures. Now, you would think that regulators would demand a fairly high level of evidence that such a potentially hazardous device really does what it says on the tin, that it improves outcomes for patients and is very safe. In actual fact, CE mark approval for guard wire was granted on the basis of one 22-patient study with no control group. In the US, the FDA demanded a bit more evidence, but still gave FDA approval on the basis of one 800-patient, multi-centre randomised controlled trial. Now, clearly, designing and conducting a study to clinically evaluate a medical device is much more complicated than a drug trial. It's relatively easy to randomise a small tablet, an identical placebo tablet, to two identical groups of patients, all other things being equal, and the doctor's blinded to which is the active drug and which the placebo. Medical devices, on the other hand, usually make up one element of a bundle of complex interventions that are difficult or impossible to randomise, blindly or otherwise. To make things even more complicated, variables like the skill of the operator can drastically alter the effectiveness of the device. These are not excuses for the lack of evidence for the effectiveness of medical devices. None of these evaluation problems are insurmountable. They just require more sophisticated study designs. In the last couple of years, the European Commission has introduced much more stringent regulations for medical device approval, partly in response to some horrific scandals, such as the use of industrial-grade silicone in breast implants and metal-on-metal hip replacements. I'm not sure what is more astonishing, that somebody could even contemplate the use of industrial-grade silicone or a metal-on-metal hip, or that no evidence base was required to get these devices approved. The new regulation states that, for Class 3 medical devices, manufacturers should, as a general rule, submit data from systematic clinical investigations that not only verify the safety and performance of the device, but also establish clinical benefit, defined as the positive impact of a device on the health of an individual, specified using meaningful, measurable, and patient-relevant clinical outcomes. So the evidence base for drug treatments is strong, but real-world medical practice still lags behind the evidence, and some of our most popular drugs don't actually do what they say on the tin for the majority of people taking them. For medical devices, the situation is much worse, because until very recently, regulatory approval has not been based on evidence of clinical effectiveness. The question, does it do what it says on the tin, is rarely asked. Let me finally come to AI health technology. Where does that leave AI software as a medical device? To paraphrase a line from the classic British sitcom Blackadder, clinical evaluation of a medical device is like a dog that speaks, rare. Clinical evaluation of AI software is like a dog that speaks Norwegian, exceedingly rare. Is this a problem for healthcare? Absolutely. The lack of evidence that AI health tech does what it says on the tin is a big, big problem for healthcare and for the AI health tech industry. Without clinical evidence of validity to persuade a naturally conservative and justifiably sceptical medical profession, first do no harm, says the Hippocratic Oath, then, as Eric Topol says, AI is not going to get legs. As the regulators start to demand that evidence, it will get harder for AI products to get approved. But in my view, a huge problem in the last few years has been the AI marketing hype that has been filling the vacuum left by the lack of evidence, undermining what little trust the medical profession had in AI and wasting everybody's time and money. All new technology is prey to the cycle of hype. When a new tech product is first launched on the market, expectations for what it can deliver invariably increase exponentially in a very short period of time, rapidly reaching a completely exaggerated peak of expectations. From there, the only way is down, and just as quickly the product starts a downward trajectory of customer disappointment, descending into a trough of disillusionment. After a while though, often, as the product matures and a more realistic assessment of its benefits emerges, customer interest slowly increases again, the product passes through a path of enlightenment, and finally, sometimes several years and several iterations after its initial launch, the product finally finds its plateau of productivity and value in the marketplace. Usually that plateau is well below that initial peak of exaggerated expectations. Perhaps the best illustration of how even an AI health tech product developed by one of the oldest and most respected tech companies in the world can become a victim of the marketing hype cycle is IBM Watson for Oncology. It provides a salutary tale for what happens when the hype cycle goes into overdrive and nobody bothers to even ask the question, where's the evidence that it does what it says on the tin? IBM's Watson was born from a single marketing idea: to regain IBM's supercomputing crown stolen from it by the young pretenders Google and Apple by building an AI model that could beat a human all-time champion on the US TV quiz show Jeopardy. This was a feat far more challenging than beating a human at chess. It would require a question-answering software architecture that combined natural language processing, machine learning, a lot of processing power, and an awful lot of data. And IBM did it in a high-stakes game, for IBM shareholders at least, live on national TV. And Watson stunned the world by winning. With a birth like that, it was hardly surprising that when IBM decided to launch Watson in the field of healthcare, the trajectory of Watson's hype cycle curve hurtled almost vertically to a vertiginous peak of exaggerated expectations. A headline from 2011 read, "IBM's Watson wins Jeopardy. Next up, fixing healthcare." John Kelly, IBM's then head of research, claimed Watson can read all of the healthcare text in the world in seconds. IBM Watson's first commercially available AI product was Watson for Oncology. Watson for Oncology is a cloud-based clinical decision support tool trained using machine learning by doctors at one of the USA's top cancer hospitals, Memorial Sloan Kettering in New York. IBM sales reps were quoted as saying that Watson for Oncology could even identify new approaches to cancer care. We were originally approached by IBM to purchase Watson for Oncology back in 2014 for the Guy's Cancer Centre at Guy's and St Thomas's NHS Trust. We decided not to buy it at the time because we could find no evidence of its effectiveness or cost effectiveness. By 2017, Watson for Oncology had started its descent of the AI hype cycle. In late 2018, the Wall Street Journal said, more than a dozen IBM partners and clients have halted or shrunk Watson's oncology-related projects. Watson cancer applications have had a limited impact on patients, according to dozens of interviews with medical centres, companies and doctors who have used it, as well as documents reviewed by the Wall Street Journal. Right now, in 2020, Watson for Oncology is down in the bottom of the trough of disillusionment. IBM Watson Health has actually pulled the product and is planning a relaunch of a new AI cancer product in 2021. The Watson for Oncology story doesn't end there for the Guy's Cancer Centre. We recently launched one of the first AI clinical evaluation units for cancer. Our unit is a joint venture between Guy's Cancer and the King's Technology Evaluation Centre, KITEC for short, at King's College London. KITEC has over 9 years of experience in health technology evaluation and is part of our new £20 million London Medical Imaging and AI Centre for Value-Based Healthcare. Our AI Clinical Evaluation Unit combines the wealth of integrated clinical and genomic data, clinical care and research expertise at the Guy's Cancer Centre with the academic evaluation and AI development expertise and resources of King's College London to create what we hope will be a world leader in AI clinical evaluation in cancer care. One of our first clinical evaluation projects has been to work with IBM Watson Health to clinically evaluate Watson for Oncology in our breast cancer pathway. And actually, our preliminary findings are very promising. We set the hype to one side, reset our expectations, and investigated a more realistic use of Watson as a triage tool to deal with the less complex breast cancer cases so that they could be referred straight to the treating physicians, leaving the more complex cases to be reviewed at our multidisciplinary tumour boards. Our early results suggest that once UK-US practice differences and drug approvals are taken into account, Watson actually performs as well as, and in some cases better than, a human triage by a single oncologist and surgeon at Guy's Cancer. For us at least, Watson looks like it may already be starting to climb the hype cycle curve again to a more realistic plateau of useful productivity. When we began our AI validation work at Guy's, we quickly realised that there was no national or even international consensus on how to evaluate AI in healthcare. We did, however, find that a number of organisations and institutions were starting to propose validation frameworks and evidence standards for AI health technology. So we took the best of them from the likes of NICE, WHO, the FDA in the US and BSI in the UK, the Alan Turing Institute, UK Medical Royal Colleges and others to create our own AI health tech validation framework. It's a work in progress and we are happy to share it. We're using it and testing it in our Guy's Cancer AI Clinical Evaluation Unit and at the AI Centre to evaluate if promising AI health tech products do what they say on the tin. We've developed 18 criteria of validity and a set of questions that need to be addressed to evidence that these criteria have been met at each stage of the AI product development life cycle, from product inception through to product development, assessment and early adoption, routine implementation, and routine monitoring. This slide shows the criteria and questions to be addressed even before the algorithm is developed. And this slide shows the criteria and questions to be addressed during product development. This slide shows the criteria and questions to be addressed during product assessment and early adoption. This slide shows the criteria and questions to be addressed during routine implementation. And this slide shows the criterion and questions to be addressed during routine monitoring. I'd like to end with another quote from Eric Topol. He said, "I think the hype is proportional to where AI could take us, but it hasn't taken us anywhere substantially yet. It will, I think, I'm confident it will, but we don't want to put the cart before the horse." To prevent that happening, and to reach the plateau of productivity for AI health tech, we must all continuously be asking and trying to answer the crucial question, does it do what it says on the tin? Thank you.